Good morning and welcome to HealthLeaders Technology Now Online Summit. My name's Eric Wicklund. I'm the Senior Technology and Innovation Editor for HealthLeaders, and I'm going to serve as your moderator for today's event. This session, is titled Analyzing the AI Landscape, What's Working and What Isn't. And this is the second session of a 3-session day for technology now. It's going to be a fascinating conversation. As I was mentioning before, I am in Vegas at the health conference, and there's so much conversation about AI on the floor, on the stages, everywhere there. It's top of mind for a lot of people, so we should have a really good talk today. This session is brought to you by Nuance. Thank you to our sponsor and to you and our audience for giving us the time and attention today. I know everybody is busy. Before we get started, I've got a few housekeeping details here. Our program will be 60 minutes in length. Note that an on-demand version of this program will be available approximately one day after the completion of the event and can be accessed using the same login link that you used for this live program. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and PC speakers for optimal sound quality. Next, you'll find a resources list for today's webinar in the upper right of your screen. Here we've listed the event program guide for you to download that provides topics and panelist information from each session. And as I said, we've got 3 of them, along with materials from our sponsor. And at the bottom of this console, you're going to see multiple widgets. To submit a question, we will have a Q&A part of this presentation. It'll be the back end, last 10 or 15 minutes. Please click on that Q&A widget. It could be open already and appear on the left side of your screen. You can submit questions at any time. Just note that we'll most likely be answering them during that Q&A session. Finally, should you experience any technical difficulties, and we know those will happen during today's program, and you need assistance, please click on the help widget, which has a question mark icon and covers common technical issues. Now, I want to jump right in. We have 4 great panelists for today's conversation. It's my pleasure to introduce them. Erica DeBoer, Chief Nursing Officer for Sanford Health. Jonathan Handler, Senior Fellow for Innovation and Adjunct Associate Professor at OSF Healthcare and Northwestern University's Feinberg School of Medicine. We will have, Sanjay Patani, Associate Chief Medical Officer of Mission Control at Advent Health, Central Florida, and Dr. Reed Conan, CMIO for Nuance. Thank you all for joining us. And with that, I'm just going to jump right into the questions here, and I have to click. There we go. That's to the first question, and I'm going to start with Reed on this one. How are you using machine learning and AI in clinical processes? And are there any specific AI initiatives planned over the next 2 years?
Sure. Thanks, Eric. First of all, thanks for hosting, and thanks everyone for joining. As Eric mentioned, I'm CMIO at Nuance. I'm also a practicing emergency department physician and clinical informaticist, board certified in emergency medicine and clinical informatics. And so just on this topic, we've seen quite an evolution in the application of AI into clinical processes. And more recently, we've certainly seen the incorporation of the use of speech recognition quite broadly in clinical medicine, really becoming a critical app in terms of documentation and workflow management. Also, the incorporation of various clinical decision support tools that are AI-based, and in addition, machine vision for radiology interpretation. And so some exciting work being done there. Automation of code stroke activation, for example, based on machine vision reading CT scans for stroke patients with a dense MCA sign, things of that nature. So some amazing progress, and even robotic process automation, or RPA, in RCM, or revenue cycle management. So these are some key areas. And over the next couple of years, my organization, where I practice clinically, Tri-City Medical Center in Southern California, and others that I've had the opportunity to work with, broadening of these type of solutions and approaches, deeper incorporation into the clinician workflow, and really leveraging these strengths. Also, the introduction of ambient speech is a big deal, and so we're seeing some numerous initiatives in all of those areas. It's really pretty exciting. Thanks, Eric.
Okay. Yeah. John, talk about a little bit about what you're doing with AI.
Sure. We have actually two teams. We have an advanced analytics team that makes predictive models that are specifically requested by the care teams, which tells you a lot right there about how much AI is a part and parcel of modern medicine today, when you actually have members of the care team specifically requesting it, as opposed to the technologist pushing it onto the care team. So we're seeing a lot more pull than we did before. We also do have in an innovation team that's we're all part of the innovation team, but that reaches farther out and says, what are some things that aren't being requested, but we think may make an innovation difference in terms of delivering care and helping us to operate more effectively. So we already have a readmission risk model, which helps us to make sure that we do the best that we can to discharge patients, avoid discharging patients before they're ready. If we think they're at high risk of getting readmitted, can we put processes in place to help keep them happy, healthy, and at home? We have, of course, everyone has an adult a sepsis model, and we have a complex discharge risk model. For example, if there's a patient who's inpatient and we think there's a high risk that they're going to be a complex discharge, have a lot of needs, it's good to get that work underway before we write the discharge order, because sometimes it takes a lot of planning, and a number of other models, precision staffing and other things that help us to manage the system. On my side, for example, we've built a near-term mortality predictor. Instead of predicting mortality during the current in-hospital stay, we've got a predictor to say within the next 5 to 90 days, likely after your current hospital admission, what is the likelihood that your likelihood of mortality, so that we can have the right conversations with patients. We find too many patients don't have any planning about end of life, and then the outcome of that is we don't do what they wished we would have done. So we want to identify who are patients who are at risk, and make sure that we want that conversation on every patient, every single patient. But in a world of limited resources, we have to focus on those potentially most in need. And then finally, we have cancer patient navigators. They're unfortunately overwhelmed at times with the number of cancer patients that come in and need their help to navigate the system and get through their care quickly and effectively. And so we have AI to help manage their workloads. And so we've got, through operations and through clinical work and everything in between, we have AI that's starting to make its way into the system. And a lot of it is a pull rather than a push.
Nice. Okay. Erica, let's talk a little bit about what you're doing up in Sanford.
So appreciate that. Thanks, Eric. We have a very similar landscape as it relates to the adoption of AI. We have an enterprise data and analytics team that, although there's tools out there that help to solve problems in our electronic medical record, we also have clinicians that are highly engaged and interested in understanding a little bit more about how we actually even estimate what our kidney disease rates might be based on lab results. So again, it's really automating any kind of workflow, any kind of information that we have in our electronic medical record to make it easier for our frontline teams to pull together what that story of the patient is, so that we can continue to take care of them the best we possibly can. So to John's point, we have some adoption. We've got some of that pull that's happening, but still some push that needs to happen specifically in our nursing workflow. So we have some predictive models that we've built around fall risk, not just for the inpatient, but how do we then plan for that risk reduction, not only in their home health stay, but also how do we get them back to home in a safer manner that way. I think John highlighted just briefly, but I would like to talk a little bit more about how we're using AI to help predict what our staffing needs are. So not only can we make sure that we have the right teammates taking care of patients, but what does that census look like? How do we use all those data points to best and effectively take care of the patients that we have and anticipate then what our census might look like, and then how do we offer more flexible shifts for those teams that are taking care of our patients. So just a couple examples. I think what I'm most excited about in the next couple of years is how do we continue to engage our frontline teams to automate more of those workflows, to a certain extent, take some of the traditions we have and almost break the mold so that we can continue to use data to help us work smarter.
A good point made. As I go into the next question, I mentioned a minute ago, a lot of the discussion here about AI, a lot of the discussion also about the fact that technology is used to help the caregiver as much as the patient. I mean, we can talk about AI for clinical outcomes till the cows come home, but it's also got to be used to help combat the stress and depression and burnout that we're seeing in the workforce now. Which leads us right to the next question. For AI to work, there's got to be a confidence level. What's the confidence level of your clinicians with AI, and how much has that perception evolved in the last year? I mean, we've seen a lot of evolution in AI. Let's start with Erica on that.
So as it relates to confidence, I think it's transformative change. We've got some amazing early adopters that are really looking at it to help them actually work smarter and have a more portable method of taking care of patients, as well as just manage their workflow. So I'd say our radiologists, our cancer care specialists are a couple that are really on the forefront. I think some of the other individuals that we're spending a lot of time with as it relates to adoption of AI technology is in our behavioral health spaces. So how do we make sure that we can actually anticipate what the behavioral health needs are of a patient and actually risk mitigate those that have the highest need versus the others? Again, it takes engagement, and it also takes adoption of those tools by our clinicians to help us actually work smarter as it relates to that. So I'd say that the transformation age, and I think COVID actually taught us a ton about how when we're focused on a certain problem and we have the majority of the tools at our fingertips, we can actually work a whole lot smarter together. And as we look at adoption of AI, it's really a mandate anymore, just given the number of workforce challenges all of us are navigating, as well as the chronic diseases of our patients.
Nice. Okay. I'm going to go to Sanjay on this. What's the confidence level of your clinicians with AI, and how have you seen AI evolve and the support of your physicians for AI evolve over the last year?
Yeah, thanks, Eric. Can you guys hear me? I hope.
Yes.
So I agree with Erica on a lot of points, actually. Historically, AI, I think, since we're kind of in the infancy, to be quite honest, of how do we incorporate AI, actual front boots on the ground workflows, right? And I think, as y'all were alluding to earlier, how sometimes people have felt like they're actually working harder, not smarter. And so I think, some of the challenges in the past have been increased sensitivity at the expense of specificity with certain AI models, especially, for example, in radiology that was commented on earlier. I think, though, however, physicians in the workforce are starting to see and realize how AI can bolster and support their workflows and adjust like their queues, if you will, of their work lists. What they used to have to go around and get information is now being handed to them in multiple different fashions. I think that the AI, as we incorporate them into workflows and have our physicians at the forefront of how we do that, is going to be the key in the future to the adaptation and to the actual implementation of the real use of that AI, because there's the AI and the HI, right? And so really at the physician level and workforce level, for them to appreciate it, they have to be able to use it in their day-to-day activities. But it's gaining a significant amount of momentum across the organization.
Nice. Okay. John.
Yeah, I think just like anything, as soon as you put out something new, people are skeptical of it if they don't already know it, and it needs to prove itself. The interesting thing is, once it proves itself and becomes part of the workflow, no one even remembers that it's AI anymore. It's just a thing that you have. It's like an automatic transmission. The thing's a marvel of technology. It works like basically perfectly every time. How often do you think about that when you're driving the car? It's just there, right? And the EKG automated readings that we've had for so many years, and the alerts that we have on many of our sensors and monitors, those are all driven by algorithms and AI, and we just take them for granted now because we know them and we trust them and we work with them for so long. A lot of it, as Sanjay points out, is how does it go into your workflow? As soon as the way it enters your workflow is through alerts and distractions, then you've got to get your false positives just right, and you've got to make sure that it's not distracting and creating overhead. Once you get the workflow right, once you get the accuracy right, once people come to trust it, then it just becomes part of their workflow, and they forget each time you bring in new AI that they already have AI and they use it and they're comfortable with it all the time. And now we just have to say, is this new one also good, and did we deploy it properly? So I think that's really the key that we found, is that once people get used to it, they don't even remember what it is.
Yes. Yeah. Reed, that same question, which was the last question, but I also find it interesting that we jumped right into this conversation on AI. And a year ago, we would have started with a question, what is AI? And we would have had to define it. I think it is defined. Reed, what are your thoughts?
Yeah, I agree. That's a good point, Eric. We're all becoming more comfortable with it as in our daily lives and also in our clinical practice. I would say that my experience with providers in my organization and others is that confidence has our confidence in AI, generally speaking, has increased dramatically. Not only in the clinical setting, but on the home front, right? Many of us are using virtual assistants at home to check the weather, order things, what have you. And in clinical practice, it's become a part of our daily lives and practice. And I agree with Eric's point that it is, or I agree with the point that was made that it becomes seamless. It becomes not noticeable to the provider of what the basic tool is, what the underlying technology may be. It just becomes a part of their practice. There's data presented in proper context that helps us to make decisions. We find we've seen increased accuracy in various tools that we're using, from clinical decision support to various documentation tools, interaction tools with patients, and that just improves our quality of care delivery and decreases risk and improves outcomes.
Nice. Okay, next question. And here's a good one too. Was it a challenge achieving buy-in from management or other departments to use these tools? Let's start with Sanjay on this one.
Okay, great, thanks. So I think yes. So obviously you have to have in any organization, I think the success and key to implementation is actually top-down leadership support. Unfortunately, that's also, you can reflect that and circle back on, well, how do I get leadership support? How do I measure the actual impact that we're going to have? What's the value proposition that this AI is going to be giving? And do you translate that to cost reduction, or do you translate that to increased quality? The answer is yes. I think one of the challenges historically, and I know my colleagues and peers will agree to this, is measuring sometimes those KPIs is really hard outside of a population health kind of benefit. The exact tangible ROI as measured to a specific program that you're putting in place that has significant downstream effect on multiple shared services. I mean, it's not really going to be a revenue enhancer to your CFO, but to your CMO, it'll be significant as far as the impact on quality. So those are the challenges, depending on who your audience is in the C-suite or, catering to, making sure that we're addressing patient care delivery model in a more efficient way. Those are great conversations that I think we all are challenged with having with our C-suites.
Okay, great. I'm going to jump to John on this one.
Yes. I was surprised. I only got to OSF Healthcare, where I currently work, about a little more than a year and a half ago. And one of the first things that I was asked to do came from our leadership, and that was around the predictor, our mortality predictor, to facilitate our end of life care planning workflows. And so, in fact, much of the work that we're doing is actually being driven by our management teams who want to embrace artificial intelligence and have it help us to provide better care and to manage our operations appropriately. A big challenge is making sure that those, as we spoke about before, is that as we go to implement those, we see lots of excitement from the care teams, but they're also appropriately skeptical because they've seen some things pushed to them that were maybe not ready for prime time, or that were not. And I don't say this from OSF's standpoint. I say this throughout my career at multiple institutions, right? That every place I've ever been, the clinicians know that not everything that comes their way is good for them or good for their patients. They're all well intended, but are they going to achieve the outcome that you desire? And so really at the end of the day, it's around having the data and the proof points to say, this thing's for real. And we've thought carefully about how to bring it into your workflow, and then to be agile about how you deploy it so that if it's not working right, you can adjust and if need be, remove.
I love, John, that you mentioned agile. If I may just jump in briefly, because I think that's the other difference, and that's the other change that we have to get our people ready for, is really failing forward fast and adjusting and allowing our frontline teams to be part of that process. And without doing that, we have a tendency to manage the fringe, that 20% that maybe doesn't work, instead of the 80%. So John, I really appreciate you actually bringing that up. I think it gets back to some of that tradition that we hold so core in how we take care of patients, the care models that have worked so well in the past. But I think what AI has helped us do, and how we get to Sanjay's point about KPIs, is I use the phrase, get rid of stupid stuff. How do we get rid of the waste in your workflows? And how can AI help support that, so that we always get to what's in it for me? And then that brilliance that they have at the bedside of solving those problems more simplistically than any of us could probably figure out.
Yeah. So a key point of achieving buy-in is proving it to, showing it to them, showing what it can do, which, yeah. And I think this, it's probably safe to say there is a very healthy skepticism of AI at this point. I mean, there's just as many questions as answers about the technology. We're still really in the learning stages of that. Yeah, Reed, what are your thoughts on this?
Sure. So all great points, and I think that today we've got quite a bit of supporting data from other organizations to lean into, right? To share internally with management, and that's helpful. Even dramatically increased support levels on data from just a couple of years ago in terms of deployment of various AI solutions. So using external data to make the case is great. I also find it's helpful to reprove that internally. And so initial phases of deployment, quick analysis and review of metrics internally to review the impact that it's having can be extremely helpful in early phases, and support of those early providers with the proper optimal deployment, but then taking a close look at the early data to share that with the decision makers internally. That can be extremely helpful and supportive to any initiative as well.
Nice. All right, let's go right on to the next question. Here we're getting to the root of the issue here. What benefits have you seen by using this technology? It kind of comes back to the last question too. How do you prove it to the skeptics that it's working for you? John, I want to start with you on this one. Oh,
sure.
Okay.
Well, our predictive systems really help us to identify who is likely to need more help and attention in order to get well. And really, at the end of the day, that is so core to the mission that we all have and share. And I would say that the vast majority of everything we do probably revolves around that, right? Where are the places where our clinicians and our patients need more support, or they're going to do something's going to happen that we otherwise wouldn't expect. And can we have this AI to help us to recognize that and then to go after it? If you look at our readmissions risk model, our sepsis model, our complex discharge model, all those help us identify which patients, our end-of-life care planning, helper, all those help us identify which patients need additional attention. Even our cancer patient navigator workload manager helps us to identify which patients are going to require more attention versus less, and which of our cancer patient navigators are going to require more help in terms of managing their workload. And so all of that is really about how do we make sure that we optimize the personalized needs of care for each patient that we have. And to me, this is the biggest benefit of what artificial intelligence brings to the table.
Nice. Now, Sanjay, I know you'd wanted to make a comment on that last question too, achieving buy-in. So yeah, go ahead.
Okay, both questions. I guess we'd be remiss also if I could regress just a second, just to talk about some of the difficulty with the buy-in would be the culture, right? And I think a lot of success and failure in individual markets may also be attributed to the actual workforce you're dealing with. So you have to look at employment structures of various organizations. And so sometimes it's a lot smoother transition to data process automation and the use of AI. In workforces and organizations where you're predominantly employed model, and where you're in a hybrid model where you're aligning with private physicians and other group practices, is where I think the rubber hits the road. So alignment and partnerships is key, and that's where relationships matter, and that's how you impact the actual goal of the health of the patient when you're dealing longitudinally across a complex healthcare system. But going back to your current question about the benefits of the technology, again, I'll stratify my answer on 3 different levels. I think the benefits ping the organization, they ping the clinicians, and they ping patients. And patients are at the bottom, yet at the top. So, Q theory and how AI helps us in work list management in multiple different subspecialties is going to be truly magnificent when it hits the efficiencies of a clinician in their workflows, as we mentioned earlier. How that benefits organizations is it's going to reduce human error, it's going to mitigate risk, and translate to higher quality care. The patient at the epicenter of this whole universe is going to decrease length of stays, time in the hospital, more appropriate places to get their care. So the AI powerfully drives and aligns everyone besides the patient, but around the patient.
Nice. Okay, Erica.
So beautifully said, Sanjay. I actually parsed it out in a very similar way, that it really does get back to what's in it for me, for the patient. It actually affords them a less friction-filled situation. It uses the data that's already been captured to create that seamless experience so that the clinicians can look at a complex system of care and understand the true story of the patient. And that's like worth its weight in gold. I think similarly, when we look at the opportunity that it helps us do, it actually takes the data that it's currently captured so that we can not only plan for the patients that are in front of us, but it also helps us plan for the future so that we can actually be available and ready to serve with those resources. So again, from our consumers, our patients, how do we make it as frictionless as possible? And then for our frontline workers, be it the clinicians, our patient access teams, and otherwise, how do we use the information that's already captured to make it a frictionless workflow for them as well, just like what they see in the Amazon experience and otherwise.
Okay. Now, Reed, you kind of a larger focus or a larger look on this in that you're looking over the entire industry. What are you seeing as the biggest benefits of AI technology?
Well, one thing that I want to be sure we consider as well is what are we struggling with as providers and as an industry in terms of, well, today we're seeing levels of burnout that are just unprecedented. Pre-COVID, the highest rates of burnout were approaching 50% in some of the worst areas or worst specialties in that category. Now it's well over 60% in numerous specialties, and that entire curve has shifted to the right in the wrong direction. So there are multiple factors there, of course, in terms of staff shortage and resource availability and access to care for patients. And the patients are burned out too. The patients are frustrated with the whole healthcare experience, and it's very challenging. So these technologies that we're talking about, AI broadly, can help in having a significant impact on the burnout of providers and staff, and retention of providers and staff, right? Turnover is expensive for providers, as well as other staff, and nursing shortages are a real thing and have a tremendous impact on the organization. We board patients in our emergency department much more often than we'd like, in large part, not because we don't have beds on the floor, but because those beds aren't staffed oftentimes. And so there are many challenges in those areas that we're struggling with more than ever. And these various AI solutions, clinical decision support, speech, ambient, you name it, machine vision, all of these can have a tremendous impact in a positive direction for our providers, at improving the quality of care and reducing burnout.
Great. Thank you, Reed. Next question here. Okay, we've talked about the benefits. And as I've said before, there is a healthy skepticism to AI. So let's talk a little bit about the challenges. What challenges or limitations have you seen in using this technology, and how are you addressing them? I got you right here, Reed. Let's talk a little bit about it from a system-wide point of view. What are the challenges and the limitations right now of AI?
Sure. I think in deploying AI solutions similar to other technologies, when we deployed the EMR in general, or various modules, training is very important, right? So familiarization, helping providers to understand what the key benefits are, why they're using these new tools. Nobody likes change, and that change management is extremely important in terms of the impact, the adoption levels, the utilization of these new technologies. So understanding what the benefits are, understanding the key areas to become familiar with in these tools, and how to incorporate them smartly into your workflow goes a long way. So super user involvement is another very important factor in deploying these solutions. Support from the top, as was said earlier, so executive level support in deployment of these AI solutions, and that can be supported by data and driven by data and outcomes prediction as well. And so those are a few important factors, but it does make a huge difference in adoption and satisfaction with these solutions as to how you optimally deploy them.
Okay, Erica, what are the challenges and limitations you're seeing?
I think I alluded to this earlier. I do believe that there is a tradition in healthcare that creates some of that pushback and the challenge of adoption. I think additionally, there's a human component to taking care of patients that AI can't solve for. So I don't think that we can ever assume that it's going to do all the work. And so it should just be that support system to help us actually do our work smarter. The other piece that I think about, to be honest, given the age of cybersecurity and all the things that we do to protect our people, is the limitations are we make it so seamless and amazing that without it, I'm not sure that we know how to manage, given some of just the procedures and the things that we've been doing to plan and prepare for what would it look like if we did have a cybersecurity event. So some of that automation as we train our new workforce coming in, it's assumed that this is going to be how they do their work. So without it, how do we understand how to take care of patients?
Nice. Okay, Sanjay.
Yeah, thank you, Erica. I think that was well said. I'd probably answer this in two different aspects. Number one, some of the challenges that we've had, as has been mentioned earlier in this talk, is how do we decrease the cognitive burden for our providers? However, we're in a workforce right now that's unique because we have a very mature workforce, but we have an incoming immature workforce. And so I think, unfortunately, some of the friction and healthy tension has been with the maturity of our workforce and physicians as far as increasing their non-clinical tasks. That's what it's viewed, whether it's nursing or physicians or whatnot. And this was alluded to earlier by how AI then is translated to the front lines through multiple alerts, and you get the alert fatigues and stuff like that. So I think that the challenge is how do we, again, decrease that noise and make it more meaningful for the front lines to use and implement that at a clinical decision point, which was agreed on earlier. So the second point is, though, again, going to Erica's security issue, is I've heard a lot of skepticism around the security of the data. So the AI is all about data, as was mentioned. It's data now, data later. Is this cloud-based data? Is it data that's owned by who? And who else has access to your data? So as healthcare systems form consortiums and the trust factor enlarges, I think that we're, growing out of our own britches, if you will. We're learning that there is a common good, and AI is just our vehicle with which we can join hands and really make a significant difference using even synthetic data. To get to population health and to meet disparity and equities in our healthcare populations, because our demographics are different. So when we all bring that together, I think that challenge and limitation, if you will be overcome.
Nice. Okay. John.
Yeah, one of the tenets that we always try to practice is under promise and over deliver. And one of the challenges that we've seen is that very often we see metrics that overpromise on these predictive models and then underdeliver. And we looked very carefully into why is that the case. I'm going to put in a plug for a paper that we just recently published in the Journal of Biomedical and Health Informatics on this topic and our solution to it. What we recognized was the statistics that we have are not the right statistics for the need that we actually have. The statistics that we have, first of all, you'll see like the area under the curve was 95%. Why is it 95%? Then we put it into place and we get tons and tons of false alerts, as Sanjay pointed out. And the answer, number one, is that's the wrong statistic to be using in the first place. So we talk about that in the paper. But the second thing is that the fundamental concept that the correctness of the prediction always correlates with how much benefit it created for the users is not accurate. If I'm busy doing CPR on a patient, I don't need the predictive model to fire a loud alarm that distracts me from that work, telling me the patient may be in trouble, right? The system is correct, but it is not providing benefit. In fact, it's actually probably creating harm by distracting me from my work. But that's the way our models work today. That's the way our statistics work. Every time it annoys you, telling you something that you already knew and were already attending to, it takes credit for that in the model, even though the users experience it as something negative. So we created a new form of statistics called utility-based statistics that takes sensitivity, specificity, positive and negative predictive values. And it's a very intuitive way of doing it. But at the end of the day, it's a fundamentally different and more relevant way of assessing models, so that when we say this is how the model is going to perform, that is much more closely mirrors what the clinicians will actually experience, so we can make better decisions about it. So a key limitation is that the models overpromise and underdeliver. And one of the ways we addressed it was, fine, we will create a new mechanism for doing those statistics, and we think it's a much better way of doing things. I have a blog post on this, zeroeffectors.com, if you want to take a look at it.
Very good. I like 4 very good answers there. Moving on to the next question, and let's see, we are, 40 minutes now, so we've got maybe another 10 minutes or so to talk about these questions. And I've noticed we got a couple good Q&As coming in. So let me see, what has surprised you about using AI in clinical processes, either good or bad? Let's start with Sanjay on this one.
Okay, so I'm I gotta admit, I'm a little schizophrenic on this question and the answer here, for the good and for the bad. So I'll say that I think it's truly exciting where we're going as far as how we're incorporating AI. Healthcare is supremely complex as we all understand it. But where we search to develop that in longitudinal transitional information streams, where are we creating barriers to share that information, as we alluded to in the previous discussion? But how are we helping the progression among various enterprises? In the vertically integrated healthcare system, you have the hospital, you have other partnerships, you have third-party payers. So how are we sharing this information? How are we creating impact without offering barriers to other people to operationalize on? I think our healthcare system, for the good and for the bad, have multiple challenges in it. But I'm really, I'd have to say that, from the trend of inpatient to outpatient that we've also seen, I think that perhaps something that we'll be looking at is the focus to shift away from hospital-based AI and looking more towards, different venues, care outside the hospital, hospital at home. Something that brings up topic-wise is all the multiple players in that space right now, because you have multiple vendors competing in silos for information and delivery of these little remote monitoring services. So our challenge as a system is going to be, how do we bridge those and bring it back to patient care and translate it longitudinally?
Nice mention of remote patient monitoring and hospital at home. Two very popular topics. We're going to be seeing a lot of them in the future. Reed, what has surprised you about how AI is being used?
So, Eric, I would say in general, the rate of acceleration and evolution of the technologies has been somewhat surprising, very exciting, and it's become almost exponential just in terms of the evolution of some of these technologies that are now incorporated into our workflow and our daily practice. And we're seeing, fairly rapid advances and also intersection of varied technologies. So it's the incorporation of clinical decision support tools and rules-based, but true AI-based algorithms and decision support tools into our practice that are creeping in ways that we may not always realize on the surface. But that seems to be accelerating, and in a very positive way. Another example would be, on the front end documentation side of things, and you've got simple speech, but now there's incorporation of decision support there, natural language processing, ambient, other technologies. It's where we're going to see the exponential benefits is when we have intersection of these tools, and that's starting to happen very rapidly. On the downside, I'd say that what's sometimes surprising is, I don't know if it's surprising, but it's impactful, is the long memory that providers have when there's deployment of a solution or when they're burned by a solution that was poorly deployed or maybe led to alert fatigue or other issues and challenges. Providers have a long memory, and they're much more resistant to adopting similar technologies in the future, and you've got to break through some of those barriers. So those are some of the challenges and surprise points that we've seen.
Once bitten, twice shy. Nice.
Yeah.
Nice. John.
I think what surprised me about using AI in clinical processes was my belief that what AI would do was identify, for example, a patient who looks perfectly fine, but something terrible is going to happen, and nobody would ever have figured that out. It turns out that's typically not where AI shines. Even if AI does do that, when the clinician goes and evaluates the patient, if they look perfectly fine, they're not going to believe the predictor anyway. And that where the real value for much of this lies is when the predictor just does the AI does a whole lot of work that the clinician doesn't now have to do. Yes, if the clinician sat down and graphed every data point for the next half hour, they would maybe come to the same conclusion as the AI, but they don't have the time to do that. And so I think a lot of what AI is bringing to the table, both in speech recognition, when it helps help the clinician avoid having to type everything out, when it's creating a calculation that comes to a conclusion the clinician, given enough time, might have come to themselves. In each of these cases, when the AI is both right and saves the clinician time, that's where we've seen the most value. It's not that it comes up with something we never would have figured out under any circumstances. It's when it helps you identify something that you're too busy to figure out for yourself, because we are all overwhelmed in healthcare right now and have been for probably many decades. And this is where AI, I think, shines.
Looks like Erica approves of that. Your turn. What surprised you the most, or good or bad, about AI?
Honestly, I've been engaged with a lot of work around early adoption of AI for a long time, specifically with our electronic medical record. And I think the thing that surprised me most in the beginning is the accuracy, and in all actuality, the inaccuracy. To John's point, it does take a clinician, and they have and will notice some of these things and then not trust the data if they didn't see it first. So that's one thing. And then the challenges of adoption as well. I think the other piece that's quite astounding to me, that continues to surprise me every day, is how we continue to learn from one another through data, as well as optic processing, and some of the things that actually, why didn't we take advantage of this in the past, to really make sure that our patients' care was at the highest quality possible, and we could anticipate some of the needs of the future. I think the other piece that I think, Sanjay, you may have mentioned this as well, is I'm amazed and surprised at how many different companies are actually coming up with different point solutions to help us solve small niche problems. And in an integrated system our size, it's very difficult to decide, is that the small problem that we're trying to solve, or how do we actually use some of these solutions to grow and innovate and understand something at a more comprehensive level from a point-to-point solution. I think, Sanjay, back to your point, it isn't going to be about inpatient acute nursing or acute care anymore. I come as an ICU nurse, so I love data. I love any type of information that's going to help me take care of my patients the best way possible. But to your point, it's not going to be about those data points anymore. It's really going to be about how they actually live their daily life and how we can actually help them with their chronic disease management and wellness. So,
very good. We have about 12 minutes left in this session. I know we have to cut this at the hour because we got another one afterwards. I'm getting some really interesting questions coming in the Q&A box, and I wanted to push a couple of those out as well. There's some long ones here. There's some, and I know we're not going to be able to get to all of them, but I'm going to find a way to have these questions answered at some point. One that came in, and I'm just going to read this right out. It's a very specific example. AI does not have the capability to formulate a patient's complex situations and need the physician's input and knowledge. In addition, insurance plans are complex and limited in coverage for particular office visits and tests. So this needs to be considered. Otherwise, it leads to costly bills for the patients. Patients have to be knowledgeable about healthcare and insurance, which is very complex. Where does AI fit into this complex situation? Does someone want to start on that? I'll leave this open to the table.
I'll take a stab at it first. I think we touched on it very briefly. Whereas organizations and healthcare systems will be working on multiple initiatives to identify, multiple needs of a patient. Again, looking at an outpatient need, and let's look at a radiology finding for fatty liver. Well, we all know the transition from fatty liver to cirrhosis is a possibility. So how do we partner now with our third parties, our Blue Cross, our independent payers, to advocate for our patients that they now will need a care progression or a care plan to fit their behavior modification needs in order to promote that that longevity, that wellness, as Eric alluded to. That is a great question, I've got to say, because it's very complex. It requires partners, not just within the health system, but also with your state regulators, your legislature. So legislation, as we all know, always falls behind and lags innovation. And so we have to do our part advocating for the right thing to do too at a legislation level. So partnerships with our local government officials will also help.
Certainly. With the Q&A questions, I'll leave this open to anybody. Would anybody like to comment, or would you like me to ask another one of these questions?
Yeah, I'll toss out that one of the challenges with one of the issues here is that the system is so complex, and I heard that, and not all the data they don't always have all of the data, and all those are key issues. Very often when an alert fires for a clinician about an allergy, the clinician knows that the patient doesn't really have that allergy, but it's not documented in the record. So technically the alert is correct based on what the system knows, but based on what the doctor or the nurse actually knows, that's not actually a correct alert. And the issue there is a bunch of missing data. So, but we do have to balance the issue of privacy versus data sharing and make sure that we do the right thing. At the end of the day, though, this data more data has to get into the system for these systems to be able to get smarter. They can't know they can't make up data out of thin air. And here's where I'm hoping that blockchain may end up being a technology that may help us to allow data sharing in a way that's more controllable and that people are more comfortable with, both institutions and patients, so that we can maintain privacy and at the same time provide the data that we need to deal with this complexity and allow these AI systems to be more effective.
Okay. And what was the name of your blog again, John?
ZERO Effectors, EFFECTORS.com. There's no advertising. It's just me saying whatever I feel like saying. So it's just academic.
Okay, perfect. We got another really great question here. How do you evaluate AI tech platforms in regards to care navigation efforts when deciding what to invest in? What are the pain points I need to consider when shopping for AI tools?
Eric,
yes, go.
I'll take a crack at that one. Yeah, and I also want to tie it back to the last question a bit as well. I think that in evaluating AI solutions, one thing that we look at from an organizational level at my hospital and clinical practice is what sort of impact is this going to have on our providers and our patients? How will it affect the human interaction in the visit, in the encounter, right? So we try to find solutions, AI solutions, that will offload much of that cognitive burden, that will smartly apply the technology to areas where the tech is most effective and can most directly help us to focus more on our patients. So an example might be an AI, an AI bot or an AI algorithm is far superior to the human brain at identifying and risk stratifying patients based on data that may be difficult to identify in the EMR. But yet we want to surface that information to help those clinicians make better decisions in real time and be able to focus more directly on their patients. So what sort of impact will these solutions have to quality of care, to the patient and provider experience? Will they allow the patient to turn and focus on allow the physician to turn and focus on the patient more and use that human touch most effectively where we can, right? That's going to improve the overall experience, the outcomes, the satisfaction.
Okay. Erica, you want to tackle this one as well.
Perfect. Thanks, Eric. I really appreciate the comments, Reed. I think to just piggyback onto that, I think the other questions that we work to try to answer is, what's the problem that we're trying to solve? So is it a problem that's relevant and supported by our executive teams and our operators? Is it a big enough problem for us to focus on? Additionally, I always look at what's the consumer experience. So is it an integrated experience, much to your point? read about the fact that, do I have to go to another app? Do I have to do something different that's going to create friction in the consumer experience, both for the providers and the frontline teams, as well as to the patient? I think the other top question that we ask is, what's the integration capability? How easy is it? Have they done it with other organizations? And how do we make sure that it's secure? And then probably the last big question we have a tendency to ask as we're evaluating other AI capabilities is, do we have tools already in place that we can utilize or optimize to actually accomplish the same goal? So those are just a couple of my thoughts as it relates to evaluation opportunities.
Nice, thank you. Okay, I'll tackle another question. We have, it looks like 4.5 minutes left. So, yeah, a while ago, I mentioned the fact that we were all talking about AI without defining it because we feel it's pretty much defined. But we have a question here: is there criteria that a company must have in order to call their solution AI? We use a system. We use a system that is rules-based and uses word finding, which does not even seem like true AI. So I guess we go back to the question is, how do you quantify or how do you qualify AI?
I don't think there is a definition, personally. Well, let me take that back. There is a definition, but I think there are multiple definitions, and I don't think there's a widely agreed upon single definition of that. I think there probably, in most people's minds, is a difference between a set of rules that was entirely human generated that happens to be executed by a computer. I don't think most people would call that AI. If we go back and say, where did those rules come from? They probably actually, in their original state, came from an analysis of data that was in fact done potentially by a computer. And that's how we have the knowledge that we have today in many ways. But with that said, I think many people think of AI as either machine learning, which are nonlinear algorithms like neural networks and other sorts of things that generate output, and some people are very hardcore and say, if it's not deep learning, if it's not a machine basically figuring absolutely everything out by itself, then it's not artificial intelligence. But I think the most important thing is that at the end of the day, you have a computer that is giving you some information, and people will interpret all of that as AI, regardless of the underlying technology. And the important thing, I think, as we've discussed here, is to make sure that the implementation and the execution leads to the benefits to the patient and the providers.
Yes. Mm-hmm. Anybody else want to weigh in on this? Okay. Let's see, we have 3 minutes. Actually, yeah, there's another question here I wanted to get at too. This may be our last one. As I said, we got to close on the hour because we have another one coming up. How can an organization continue to support an AI platform that is consistently inaccurate? And I'd like everybody to answer this one so we can close it out with everybody's comments. Sanjay, let's start with you.
I'm trying to get the question. I apologize. So we're going to continue with an AI platform. Okay. So, so I think Erica or somebody alluded to it earlier. All of our digital innovation in the process of AI or not has to be agile enough to allow for failing quickly. So I think our success is going to be based on our expectation is to fail. You have to fail multiple times until you get it right. And that takes a lot of resilience in our workforce. And honestly, I think to not support AI platforms, healthcare is always termed as the industry that lags 10 years behind, right? So I think it's going to come to us whether or not we want to endorse it. And I'd rather us be at the forefront of this as clinicians and health organizations than having third-party payers and or other external forces actually then give us their platforms to follow, right? There's a difference between a push-pull philosophy.
I think maybe I'd anchor back on a comment that John had made is, how are you measuring inaccuracy? Do we just not like what the data is telling us? Or how are we defining inaccuracies? And I understand that that's some of what maybe the challenge is ahead of us. But to Sanjay's point, it's here to stay, and it's going to be the thing that's going to help us actually serve our patient populations more effectively. So failing forward fast, learning from it, turning it off if it's not accurate, and attacking something that might be simpler would be the way that I would approach the scenario.
Okay. Yeah. John, okay.
Oh, yeah, I'll just say real quickly, Eric, that a lot of the AIs that we're talking about today in healthcare are based on deep learning, machine learning based technologies, and those come back to data. The quality of output comes back to the quality of data and the volume of data. And so, if you're experiencing inaccuracies in the AI outputs, naturally there'll be some of that, right? Human brain is fallible. AIs are fallible. They get better over time with training, but they also are dependent on the quality and volume of data. And so that's certainly somewhere to look at what is the quality of the training data that's being used, and what are the feedback loops like. That has a tremendous impact in terms of the quality and accuracy of AI output.
Nice. Okay. John, you get the last word on this. How can an organization continue to support of an AI platform that is consistently inaccurate?
I think the most important thing is to think about how are you implementing this thing. If you're implementing something that must be 100% right, then you should not implement something that will be consistently inaccurate. But there are use cases that where great value can be obtained even though the system is imperfect. Nothing is imperfect in medicine. We think about the Swiss cheese model of safety where nothing is perfect, but as long as the holes don't line up, this is just another layer of the Swiss cheese. And as long as you think of it that way and you implement things where the hole in the artificial intelligence doesn't line up with the hole that the human has, then the two together are better than either one alone. And those are the kinds of use cases and implementations that I think create the most value.
Great. Guys, thank you very much. It's been a fascinating conversation. We certainly could go a lot longer if we had the time, but that's all the time we have today. In fact, we have a session coming right up. In closing, please note that if you did register for the next panel of this event titled "Ensuring Data Quality in an Often Unstructured World," and we're going to have some fun with that one as well, a live clickable link will appear at the close of this session to take you directly over to the program. And that's where I'll be as well. If you have not registered for that program and wish to attend, you'll need to click that link and fill out the registration form to gain access. I want to thank our panelists today. This has been a fascinating conversation. I really enjoyed what we were talking about, and thank you for taking the time out of your busy day to take part in this. And I want to thank our sponsor, Nuance, for making this program possible. And finally, a thank you to those of you in the audience for participating this morning or this afternoon in some cases. We hope you enjoyed this session, and we look forward to seeing you in the next session and in other events in the near future. Thank you very much. Thanks, everyone.
Thanks, Eric.